For this session, we will talk about how you approach, supposing there is a suspected malignant lesion of the bone. How does a radiologist approach for a diagnosis? Actually, it is a teamwork. How to diagnose and manage bone tumors is a teamwork. First, the orthopedic surgeon, patient goes to the orthopedic surgeon or at times to the oncologist. They consult together and they say probable malignancy. And then they come to the radiologist for a radiological diagnosis. Conventional radiology, other imaging methods he uses and comes to a conclusion. Then they go to the pathologist for histological confirmation. The pathologist also consults the radiologist for a gross specimen and diagnosis and then confirms histologically there is a particular diagnosis. What are the principles of radiological diagnosis of bone tumors? There must be some basic principles for a student or a junior consultant, how he approaches. For example, age and sex are important. Unless you know clinically what the age of the patient is, I will tell you why. A patient, 10 years old boy, comes with a skull film, punched out areas are there, lytic areas are there. Just because they are punched out and lytic, you don't say it is a multiple myeloma. Multiple myeloma does not occur at the age of 10. So age of the patient is important. And sex, not so much important, although certain tumors are prevalent in males. And whether it is single or multiple lesions. A patient comes with a shoulder film. There is a lytic area in the upper shaft of the humerus, included in the shoulder. And then you don't jump to a diagnosis. Particularly if the patient age is 45 or 50, you think of metastasis or myeloma. So for that, we have to know, are there any other lesions? Years ago, 2 decades ago, we used to do what is called skeletal survey. Take the axial skeleton, lateral use of the skull, proximal ends of the femora and humeri, pelvis, and say, oh, there are no other lesions noted in this skeletal survey. But today it's not that. Today we use radioactive isotopes, technetium-99m, and with a gamma camera we take a scan and see what are the areas which are hot. Not that all the hot areas are lytic lesions or sclerotic lesions, but some of them may represent the actual pathology. So we think of a diagnosis different, which we thought, supposing it was a local solitary lesion. So that bone scan is essential. Type of bone involved. See, there are 3 types of bones: tubular bones, flat bones, cuboidal bones. Why I am telling this is, tubular bones, particularly in children, is enveloped with periosteum. Periosteal reaction comes quickly with any instigation. Trauma, infection, malignancy, benign. So periosteal reaction responds quickly in children, particularly in the tubular bones. Whereas in flat bones, such as a calvarium or scapula, periosteal reaction, not that there is no periosteum, there is periosteum, but it's so close in contact with the cortical bone, it doesn't react quickly as it reacts as in tubular bones. And similarly, cuboidal bones, say, take the corpus or take the tarsus. Although there may be a stimulus like infection, trauma, or bone tumor, periosteal reaction is not noted. So the type of bone that is involved, namely tubular bone, and site of the lesion within the bone, is it diaphysis, metaphysis, epiphysis? Because certain lesions occur only in the diaphysis. Certain lesions are prevalent in epiphysis. But most of the malignant tumors occur at the diametaphyseal region. And then site of origin of the lesion, say take a bone. Is it from the periosteum? Is it from the cortex? Is it from the spongiosa? Or is it from the vascular tissue, fibrous tissue, cartilaginous tissue? So it is important the site of the origin of the lesion. And nature and extent of bone change. Is it aggressive? Is it ballooning the bone? Is there a lot of periosteal reaction? So the aggressive nature or the benign nature should be noted in the radiograph. Appearance of the transition zone. Transition zone is the zone, this is transition between the normal and the abnormal. If it is thin, occasionally sclerotic, definitely you think of a benign lesion. If it is wide, you think of an aggressive benign lesion or a malignant lesion. Nature of the tumor matrix. What does the tumor matrix consist of? Is it new bone, clouds of a new bone, or is it cartilaginous lesion, namely circles, arcs, or nuggets of calcification? And also, you think if it is a vascular, say hemangiopericytoma or a hemangioma, you think of vascular grooves. So it is important that the tumor matrix is studied properly. Type of periosteal reaction, is it linear? If it is linear, is it unilaminar? Or is it multilaminar? It is multiple insults. Or even if it is multilaminar, is it interrupted? Is it spiculated? Sunrise spicules they call it. Or is there a Codman's triangle? Because the periosteum may be lifted by the tumor tissue and the calcification or ossification occurs along the sharp-based fibers. Or is it compact, such as you see in chronic, say osteomyelitis or chondrosarcoma? Or is it velvety, characteristic of fungal lesions or chondrosarcoma? So that is important. The type of periosteal reaction should be studied properly. And then lastly, soft tissue involvement. Is it a localized soft tissue swelling or a diffuse soft tissue swelling? Is it a cylindrical, spindle-shaped soft tissue swelling? These are important in making a firm diagnosis on radiological means. Bone tumors, how do you classify? Are they primary? If there is a primary bone tumor, is it malignant? These two you have to decide. Diagnostic accuracy, if you take all the imaging modalities, conventional radiology, particularly with the soft tissue technique, AP, lateral, occasionally obliques, 80% of the time one can come to a reasonable diagnosis. Whereas CT adds 10%. You see, the plain films may not show calcification, early calcification, whereas CT is sensitive to early calcification. Not only that, CT adds a cross-sectional view of the pathology of the bone. Nuclear scan, as we said earlier, it is highly sensitive for any either new bone or reparative bone or malignant bone. So CT scan is a little less superior in the sense, on CT scan you can't CT the entire all the bones, whereas nuclear scan in one picture entire skeletal surface is seen and the hot areas are identified. You deduct the normal areas or degenerative changes and then come to a conclusion that it is a multicentric disease. MRI, how is it sensitive? Bone marrow. In all these studies, you can't study the bone marrow. Edema, contusion, infiltration, infarcts, all these early infarcts you can study by the MRI. Not only that, it has no radiation. So it's not dangerous to the patient. Any number of MRIs you can take. Another thing is in one single sitting, you can take multiple orthogonal views. And then angiography. Rarely we need angiography in order to prove that it's a highly vascular tumor. And it adds 2% of the time, not only in the diagnosis, but in the management of the cases also. I always tell my postgraduate students, when a tumor, if you think that there is a neoplasm or a lesion, how do you analyze? One, you have to know the site. Earlier we have mentioned that metaphyseal, diaphyseal, or epiphyseal, transition zone. Already we have mentioned origin, from what structure it has arisen. Then matrix, calcified, ossified, non-ossified, or even lipomatous. Periosteal reaction, the types of periosteal reaction already have mentioned, and soft tissue changes. So if you take the mnemonic, storms, always keep it in your mind whenever you come across a lesion, particularly a benign or malignant lesion, a tumor, think of storms and analyze the lesion. And what are the common primary bone tumors? Chondrogenic, chondrosarcoma, osteogenic, osteosarcoma, fibrogenic, fibrosarcoma or malignant fibrous histiocytoma, Ewing's, myeloma. These are some of the common tumors, primary tumors. And cardioma, they're rare, but we do come across and we have to diagnose radiologically. Cardioma, adamantinoma, particularly the tibia, mandible, lymphomas and leukemias. These are hematological malignancies and metastases. Now, analyze the chondrogenic tumors, namely chondrosarcoma, common sites, femur, either upper or lower end, pelvis, iliac bones, ischial bones, humerus, ribs, tibia, scapula, hand, foot, and bones of the leg, skull, jaw, and others. These are the various sites for a chondrosarcoma, common sites. This is the cone down view of the proximal part of the femur. What do you see? There is a lytic area, there is expansion of the lesion, that's how there is endosteal scalloping, and if you look carefully, there are some calcifications. This is how a chondrosarcoma occurs, a primary chondrosarcoma. What are the secondary chondrosarcomas? Well, various, they say enchondroma, echondroma, exostosis. These are all the secondary type of chondrosarcomas. Here also, primary tumors of the axial skeleton are rare, except for myeloma. And then here you see the body fell to lytic changes, and there are some nodular type of calcifications, obviously chondrosarcoma. Another lytic area in the transverse process on the right side of L1, and there are calcifications, another case of chondrosarcoma. Say the proximal phalanx of the middle finger of a, say, 40-year-old male, and then expanding lesion, mosaic type of pattern. If you look at the trabeculae, the secondary trabeculae, some of them are resolved, some of them show prominent trabeculae, and there are calcifications. The calcification is important. So immediately you think of a chondrosarcoma. Same thing in the lateral view, almost same findings. Another, there's the exostosis-like thing in the proximal phalanx, but then there is a associated soft tissue swelling. That is important. In a normal exostosis or osteochondroma, you should not get that much of a soft tissue swelling, and there is no major bursa underlying it or overlying it. So whenever you see a large soft tissue swelling with exostosis, think of a chondrosarcoma. Lytic lesion, proximal end of the femur, below the lesser trochanter, cortex is gone, and there are calcifications in the center. By the way, if you see calcifications in a lesion, it could be an infarct too. Lots of time there is a differential diagnosis between enchondroma and an infarct. Infarct will have serpiginous type of calcifications and a fibrosis membrane at the periphery. Whereas condymatous type of calcification, as I told you earlier, nugget-like nodules, arc-like or semicircle, and then full circle, rounded circular calcifications. This again is chondrosarcoma. The cortex is broken, so we know it is malignant. And the transitional zone is also wide. Another, in the proximal shaft of the humerus, lytic lesion. The transitional zone is not that wide, but at the same time, is an expanding lesion as compared to the diameter above and below. Periosteal reaction is noted and again proved to be chondrosarcoma. Another lesion in the lower end of the femur, loculated type of lesion. Look carefully, there may be some one or two calcifications. It's important to look carefully, and if not, take a CT, obvious calcifications. Cortex is broken, pathological fracture is there, loculated type of lesion, chondrosarcoma. Ischial tuberosity, eroded, and there is a soft tissue swelling which you don't appreciate, and there is periosteal reaction in the superior part of the pubic bone. All these constitute a chondrosarcoma, although you may not appreciate the calcifications. In fact, if you take 100 chondrosarcomas, maybe 75 to 80% only show some sort of a calcification. Here again, in person, KREST Prof is not fused yet, he is about 17. Irregular calcification with erosion of the lateral cortex of the iliac bone, chondrosarcoma. Aggressive, expanding lytic lesion in the proximal end of the humerus, wide transitional zone, again a calcific nodule in the center, chondrosarcoma. Here, the ring finger is amputated with the metacarpophalangeal joint. If you see multiple enchondromata, echondromata, that is eccentric type of chondromata, periosteal chondromata are noted. That obviously is multiple enchondromatosis. But then if you look carefully, there are some fibulus, that is hemangiomata also are associated with. That means immediately it should strike you Maffucci syndrome. Multiple chondromata, hemangiomata, and about 20% of the time there are other tumors also in the gastrointestinal tract, etc. And one of them may get malignant. For example, here, the third metacarpal, irregular periosteal reaction, lysis, it doesn't look like a solitary enchondroma. This is getting malignant. Now, I don't want to go to the histological types of chondrosarcoma. There are varieties of histological types. And now we come to the osteosarcoma intramedullary. Again, there are about 14 varieties of osteosarcoma. And the most common is a garden variety of osteosarcoma. Usually the age is between 10 and 20. Usually the diametastasis is involved. And usually there is a triangle, Codman's triangle, and new bone formation. High grade, again intramedullary osteosarcomas may be divided into high grade osteosarcoma, telangiectatic, low grade, small cell, and then osteosarcomatosis, multiple osteosarcoma at various bones, gnathic, arising from the mandible. Lateral view of the thigh of a 16-year-old boy, the epiphyses are not used. Diffuse ivory type of new bone, periosteal reaction, and this new bone is extending all the way posteriorly and into the epiphysis. Classical osteogenic type of osteosarcoma, where the osteogenesis is predominant. Here is another case, not the same case, younger person, 12 years old, and you see the Codman's triangle clearly posterior. And even anteriorly, there is a small Codman's triangle, lytic expanding lesion with new bone formation, osteogenic sarcoma. One more, osteogenic sarcoma surrounding the bone, you may think, could it be a periosteal or parasteal type of osteosarcoma, but there is periosteal reaction. Although there is a lucency between the shaft and the new bone formed tumor, but still the differential diagnosis rests, is it a parasteal osteosarcoma? But if you look at the age, epiphyses are not fused. In younger patients, parasteal osteosarcoma is not common. You require 20 to 30 to 40 years in order to know and detect parasteal type of osteosarcoma. There is what is called chondroblastic type of osteosarcoma. This is one of them, only histologically proved. Periosteum is elevated, it's a shell, irregularity of the cortex, multiple trabeculae are noted. Axial skeleton is not exempt from osteosarcoma, particularly in the sacrum, because there are so many segments of the sacrum and coccyx. Woolly type of new bone formation, primary osteosarcoma arising from the sacrum. Osteolytic type of osteosarcoma, there is a pathological fracture. How do you know it is malignant? White transitional zone, new bone formation proximally, and expanding bone. Although there is not much of periosteal reaction. It is also extending all the way to the epiphyseal plate. Telangiectatic osteosarcoma, predominantly in males, second decade, knee and humerus of the common sites. Lytic, predominantly it's lytic, not much of new bone formation. Pathological fractures are not uncommon. Lower end of the femur, teenager, the epiphyses are not closed. Lytic area, eccentrically located, periosteal reaction, cortex is broken, telangiectatic.